So the next section is risks by substance, and Shri talked a lot about psychological issues that can come up, or psychological, psychiatric types of contraindications. I'm going to kind of walk through most of the major players here and kind of point out kind of what properties of these substances may introduce kind of specific or sorts of individual risks based on what you're taking. So we'll start with MDMA, and Alexander Shulgin called this one penicillin for the soul, so an antibiotic or kind of curative effect for the soul. What is it? It's classified as both a stimulant and a psychedelic. You can't take the methamphetamine out of MDMA. It is a part of it, so it is a psychostimulant as well as a psychedelic. You know, it doesn't typically, at least the doses that they're using in clinical trials, produce this sort of world-distorting type of effect that a tryptamine would, like LSD or psilocybin. It tends to be much more of an emotional psychedelic in that a lot of things can really move emotionally, but as far as like the world melting and complete ego dissolution, that's not necessarily the profile or characteristic of MDMA. And perhaps that has to do with the kind of stimulant effect, because they kind of have these scales of ego dissoluting and ego reinforcing drugs, and it seems that on the one extreme you have things like LSD or psilocybin, which are able to kind of completely dissolve ego structures, and then the other end you have things like cocaine, which tends to make people have this inflated or grandiose sense of self-esteem. And I don't know if you've ever been at a party and watched two people on cocaine having a conversation with each other, but it usually goes like this: me, 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 I, me, 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 I, right? So it's like these people just completely stuck in their own heads talking about how great they are to each other, but there's very little sort of actual listening and back and forth dialogue that's occurring.
Sounds
So,
like normal conversation to me.
Pardon?
That sounds like normal conversation.
Well, normal conversation on steroids then maybe, I don't know. So I kind of feel like MDMA is somewhere in the middle, in that you do retain this ego or sense of self, and actually some people will remark it in the middle of their MDMA experience that I feel more like myself than I've ever felt before, right? Not I feel that I'm existing outside in time and space, and this probably has to do with it seems that you have this enhanced capacity connecting. Think of it, you know, colloquially, or they kind of call it this is a heart-opening type of medicine. But really, I kind of feel that it's about reduction of fear. And this is why people feel so authentic or so themselves on MDMA, because they're experiencing who they would be in the absence or a greatly diminished kind of sense or capacity for fear. So somewhere between psychedelic and stimulant is MDMA, and it seems that the overall effect is an emotional psychedelic that lets you experience yourself without fear. So as far as dosing, this is clinical dosing. Here is the dosing that they use in clinical trials. They start with a pretty modest initial dose, 75 to 125 milligrams. And then they offer them a booster, which is exactly 50% of their initial dose around 2.5 hours into the experience. And probably the purpose of the booster is not necessarily to get the person higher or necessarily deeper, but more to extend the peak or extend that plateau effect. Because really, the peak of MDMA is usually between 1 and 2 hours. So really, if you just take MDMA, just 100 milligrams, 125 milligrams, you probably only have hour and a half at that peak. Whereas if you offer that booster, now that peak is probably extended out to 3 or 4 hours, and it just gives the person more time in that space to kind of interact with themselves. And I think that once MDMA is approved, some company is going to pick up on this and create MDMA extended release. So you just take one, and it actually, kind of gives you a hit initially, and then it kind of slowly releases another half dose over the next couple hours or something like that. And that certainly would be a patentable type of thing. And when there's a patent, there's money to be made, and there's a drug approved, the pharma bandwagon is going to come with it. Yeah.
It makes no difference what your body volume is? Like if someone weighs 100 pounds or 200 pounds, it's the same.
This is a really good question. They have not done any type of discrimination as far as weight-based dosing in the clinical studies. It does seem that women tend to be more sensitive to the effects of MDMA than men. This is actually true with methamphetamine as well. It seems like for some reason women are more sensitive to stimulants. It seems that when women use methamphetamine, they get addicted to it faster than men do, which is really kind of an interesting thing. And this isn't to say that, oh, MDMA is horribly addictive or that people get addicted from clinical trials, but yeah, I think that your question is very, very valid and not really something that's been very well studied at this point as far
It
as...
seems some people are so small and some people are so big.
Correct.
why
Some
it's
people are very, very
This is why it's
sensitive to things and some people are not. So again, it's sort of like this initial dose is pretty modest, right? You're probably not going to overshoot someone with this initial dose, and if they are incredibly sensitive or find that it's much stronger effect than they or you anticipated, just don't offer the booster.
Or the other
What
way
is it
around,
overshooting
where it's
from?
not doing anything because it's too little.
Right. So the thing with doing it the other way around is that when you take these psychedelics, you tend to get an acute tolerance to them very rapidly. So if you kind of did the half dose first and then the bigger dose later, I would predict that the bigger dose would kind of fizzle. So it's kind of like you don't want to put someone in the twilight zone, because they were actually doing this in the MDMA studies because it's very difficult to blind these studies, like, because you want this double-blinded type of thing, but you give someone MDMA, their pupils are eyes of saucers, they're like, everyone knows who got drug and who got placebo. So the kind of masking in these experiments is questionable. So what they tried to do to kind of get around that was like, hey, all right, we're going to give 125 milligrams for the active dose. We're going to give 30 milligrams for the placebo. And what they were finding actually is that placebo dose was actually giving people worse problems and side effects than the true placebo, which had nothing. So they stopped doing that in their trials going forward, and it kind of seems that, microdosing, subperceptual, macrodosing, you're fully there, but that space in between can be very anxiety-ridden and difficult to navigate. Some people do well, but some people really have a hard time there.
That's exactly what I was asking about,
Yeah.
because for some people that are really big or have a high tolerance, that initial dose could be doing exactly that.
It could be. Usually 100 milligrams or more is a pretty standard first dose, and unless you're taking some type of pharmaceutical or something that you know is going to blunt or diminish the effect, that's typically enough off the bat.
Thank you.
What about a clinical dose of 150 milligrams? I heard of that kind of dose, and then also boost with another 75.
Yeah. So yeah, exactly. So 150 and then what? A booster of 35.
Yeah.
Yeah,
I heard of
so there's different people kind of doing different things. What I'm presenting here is the doses that they've actually used in clinical studies. I've met people that like to start 175 or 200 off the bat and then give another 100, and I kind of just feel that that's unnecessarily too much, or I don't know if it's unnecessarily too much actually, but what I do know is that they have 6 phase 2 trials using this dosing regimen, and it really helps people with PTSD. And I think that from the perspective of healing, right? Like from the perspective of consciousness exploration, you want to push the dose to 200, 250 milligrams, that's on you, right? But if you're thinking about, oh man, how do I minimize risk while still getting the benefit? You're looking for the minimum effective dose. And it seems that what we know about trials so far is that this dosing scheme really works for people. So you will meet people that are doing very different things with the dosing, and some of it makes sense to me sometimes, and sometimes I'm just kind of like, that sounds a bit silly, but...
Could it be depend on how resistant is the person with
how
this
resistant they
trauma?
is and how anxious they are. So the thing about anxiety disorders, or people are anxious about taking pills, about taking treatments, right? So sometimes you meet people and it's kind of like, maybe they are a bigger person, but they're completely anxiety-ridden about going into this type of space and this experience. And it can be very psychologically reassuring for them to kind of discuss, like, hey, I'm going to start you on the lower end of what they've done in clinical trials, and that can oftentimes be very reassuring, give the person additional trust going into the experience, and from the setting perspective, okay, maybe they aren't quite fully there, but that reassurance that you gave them that I'm listening to you, I'm listening to what you want out of this experience, I'm hearing your fears and your concerns, and I'm going to slightly adapt my protocol or dosing to meet you where you're at.
How about the recipes?
Overshooting, you didn't say what might happen if someone get over.
Yeah, so what might happen if you overshoot MDMA? So some of these risks here, actually most of these risks are known from recreational ecstasy use. And it's a bit apples and oranges, and it's difficult to say what would happen, because they haven't overshot in clinical trials, and there's literally been no serious adverse effects that they've observed in the clinical studies. But as far as MDMA, it's a stimulant. You know, it increases your blood pressure and heart rate. And there have been people that have cardiovascular events like heart attacks or strokes while taking MDMA. Were they mixing it with cocaine and alcohol? Were they overweight? Were they smoking? Maybe there's some other risk factors that kind of explain those types of outcomes.
How about the recipes?
Pardon?
How about the variety of recipes, like to cook the MDMA?
Yeah, so again, in the clinical trial environment, they're using 99.7% pure types of substances. So yeah, I mean, this risk, what you're talking about, is not necessarily a risk that's particular to MDMA. It's a risk that's particular to MDMA in a prohibition environment where you have all sorts of people that are trying to make as much money as possible, and quite frankly, methamphetamine is much, much, much cheaper than MDMA, so it becomes very tempting to cut MDMA with speed or caffeine, other bath salts or cathinone types of compounds that give similar effects short term but have more unknown types of risks. So yeah, there's been pills showing up in the UK that are actually very pure MDMA, but they've got 300 milligrams in every single pill. So it's just sort of like, dang, that's a horse's dose right off the bat. So some of these risks aren't necessarily particular to MDMA, and they're more particular to ecstasy in a prohibition environment. What we do know, though, is MDMA does raise your core body temperature. Seems like in clinical trials it raises about 0.4 of a degree centigrade. In clubs, 1 degree centigrade or more. Oftentimes in a hot club type environment, you may be dancing for hours, you may be kind of lost in it, so maybe you're not drinking enough water and you're dehydrated. However, MDMA also tends to, beyond oxytocin, releases this hormone called vasopressin, which causes salt dumping in your urine. So you can end up with low sodium with MDMA, and when you drink a lot of water doesn't have any salt in it. So some people kind of overcompensate and they think, oh, I don't want to get dehydrated on MDMA because that's risky. I'm going to drink a gallon of water in an hour with MDMA, and then they basically waste all the salt out of their body, which increases the risk for seizures. Also, fever increases the risk of seizures. So you kind of think about it, this is sort of a perfect storm sometimes in the club type of environment where it's very hot, you're dancing, maybe you're dehydrated or you're overcompensating. There's some flashing strobe lights or sensory stimuli which also tend to increase the risk of seizures. So certainly in those club type environments, seizures are possible. Drug interactions, I will talk a little bit more in the third sections I have today, but particularly with monoamine oxidase inhibitors like ayahuasca is just a hard contraindication and a hard no as far as risk of serotonin syndrome.
Have you noticed some cases that especially men in the first hour cannot pee, and then what comes up, all the toxin comes up and make it a very dangerous, risky situation when they have difficulty to pee?
Like urinary obstruction?
Yeah, with MDMA.
It makes it very difficult to pee?
Yes.
Sometimes they pass.
Well, I would kind of think that maybe there's this salt wasting, which eventually will make you want to pee a lot. But maybe initially it's a stimulant, and just stimulants in general are activating the fight or flight nervous system. whereas the other type of nervous system, parasympathetic, is rest and digest. So do you get hungry on MDMA? Typically not, right? So it's kind of like you're in this kind of stimulatory kind of coming up on the rocket ship perhaps, and just those bodily functions around, well, I don't know, because sometimes in the first hour you really do need to kind of take a crap, and that's kind of like maybe the serotonin is moving something along too. But I've not heard of that it just kind of shuts down the bladder in the first hour or two of the experience, or that could be dangerous if it does happen.
And about the boost, it is something that you, after 1 hour, 2 hours? You said 2 hours.
Yeah. Yeah, you typically want to give it 2 hours before the booster.
It's more
2.5.
useful.
Once it gets to 3.5 hours, you're a little bit outside the window. It's not like way too late, but for that therapy perspective, now you're kind of creating like two kind of mini peaks, whereas like I think that the intention or goal is really to kind of create this plateaued phase. Yeah. Yeah.
If I get it right, I think the problem to urinate, it's because of the vasopressin, because it kind of signals the kidneys to retain fluids, and then the risk is hyponatremia and not toxicity. Yeah.
Right.
Is that correct?
Yes.
Yeah.
Yes.
Okay.
Yeah.
Okay. Thank you.
Can you repeat it in Hebrew?
יש קשיים להשתין עם ה-MDMA בגלל ש-MDMA גורם להפרשה של וזופרסין, שזה ההורמון שהוא דיבר עליו, ואז כשיש קושי להשתין ושותים הרבה מים, אז מדללים את הריכוז מלחים בגוף, ואז זה ה-over-hydration שהוא דיבר על זה. אוקיי?
וואו, אבל...
כן.
עברית זה יותר גרוע.
Okay. Our next
What
friend.
is the recommendation then?
Pardon?
I'm lost with the...
The recommendation is basically take MDMA in a room that is not extremely hot. If you're going to go in a jacuzzi or hot tub on MDMA, limit it to 5 minutes. Don't sit in there for 30 minutes or an hour. Drink a normal amount of water. Don't overhydrate, and don't just not drink any water. Neurotoxicity, we kind of talked about that one a little bit earlier as far as frequency of use. So, you know, if you're doing a course of MDMA for therapy, probably don't need to take it sooner than a month apart. Whereas if you're sort of like, I like MDMA, I'm a recreational MDMA user, then my personal recommendation wouldn't be to take it more than 3 or 4 times a year if you're really thinking like, I'm going to take MDMA for a decade, right? Like you probably kind of want to space it out. Because it does seem that in clinical trials, they have not found neurotoxicity. However, in recreational literature, they have found neurotoxicity. So somewhere between what they do in clinical trials and what's happening in recreational environments, there is a line that can be crossed where it becomes toxic. And that's really anything, is that, the kind of father of pharmacology, this guy named Paracelsus, really, to paraphrase him, said, everything is a poison, only dose determines that something is not a poison, right? So dose, frequency of use, things like that. And then don't combine it with monoamine oxidase inhibitors, so don't combine it with ayahuasca, don't combine it with pharmaceutical monoamine oxidase inhibitors or things like Syrian rue, which also has monoamine oxidase inhibitors in it, would be kind of the harm reduction approach to MDMA. If you are going to be in a club, okay, just, I don't know, have a buddy system. Okay, every 45 minutes we're going to go outside and just spend some time cooling off for 5 or 10 minutes, and that will be enough to kind of reduce the risk. So it's not to say that you cannot go dancing on MDMA, or you cannot drink water or that kind of thing. It's just sort of, just don't take anything to an extreme. Have a buddy system, someone that's looking out for you, so that if you do kind of lose track in time, there's someone that just kind of taps you on the shoulder and says, hey, let's go take a break for a second, right?
Alcohol, no, right?
Alcohol, I would say is not a great idea with MDMA. How much, right? Like some people, it's sort of like, because when you're on stimulants, it seems like you can just sort of drink like a fish and nothing ever happens to you. So, I've seen people, take like a half dozen shot of tequila in the first like 2 hours. And first of all, it just screws up the MDMA experience. You really just don't have as good of a roll. But then, personally, I kind of feel that, okay, if you want to recreationally, right, not in a therapeutic context, but if you want to drink a beer on the come down because it kind of mellows out the anxiety and things like that, I don't feel like that's necessarily super toxic or crazy harmful. Yeah, but certainly therapeutically, you don't want to front load your experience with alcohol and probably don't want to do it at any point in that time frame.
Ben, I just want to add, she asked about the doses, and there is a website that's called molymeasure.com where you enter your height, go, and
it tells you.
weight, and like you get a sort of average of what's it's like the IBM of the psychedelic
Okay.
area.
Only
Molymeasure.com?
Yeah,
Okay.
try.
I love these things because I'll always just learn things myself. And what that's based on and how validated it is, I'm not sure. We got to move on though, because we're like literally already an hour behind. And
How about we do all the questions at the end of the segment? That works.
it could work. What's psilocybin? It's a naturally occurring psychedelic found in mushroom. Physically, it's actually very safe. Psychologically, obviously it's a psychedelic, so it can be intense. It's associated with mystical experiences, as are most tryptamine psychedelics, but it seems like it's just most well studied with psilocybin at this point. And as far as clinical trials, depression, anxiety, life-threatening illness or existential crises, obsessive-compulsive disorder, substance use, and there's more trials on the horizon for migraines, cluster headaches, anorexia, a couple other conditions. As far as dosing of this one, it's typically 1 to 5 grams of dried mushroom. I would say 3 to 5 grams is your typical kind of like macro dose, about a 3 to 5, 3.5 grams. In the United States, it would be 1/8 of an ounce. It'd be 3.5 grams. In clinical trials, they're not using dried mushrooms though. They're using pure psilocybin in a weight-based dose actually, so 0.2 to 0.4 mg per kg. And there's a lot of variability in different species of mushrooms as far as how much psilocybin they have, as far as their dried weight. But one quote from Paul Stamets I saw was about 1%. So if you kind of took this, if you had a pretty heavy adult, right? Let's say you have a 100 kilo adult, 100 kilos, 0.4 mg per kg, that would equate to about 4 grams of mushrooms at that point. So it seems like the amount of pure psilocybin they're using really does kind of square up with this 3 to 5 grams of dried mushrooms pretty well overall. Like most psychedelics, you do get acute tolerance to mushrooms. So, you meet some people that are kind of like, I ate some and then I ate some later, or, you meet people on the internet, it's their first time, they're kind of like, I was a bit scared, so I decided to take 1 gram, and then I took another gram an hour later, and then I took another gram an hour later, and I don't really think it worked. And it's kind of like, yeah, because you build a tolerance to these drugs so quickly that, repeat dosing really doesn't make that much sense, especially if you're trying to do the macro dosing. For the micro dosing, yeah, people do take small doses, sometimes up to 5 days in a row with 2 days off, and say that it sort of retains an effect. But if you're microdosing, it's supposed to be sub-perceptual. You're not supposed to be feeling it. So maybe at that point, tolerance becomes less of an issue or less of a concern, because by definition, you're not supposed to be feeling it. So, you wouldn't know if you had tolerance or not, I guess. Yeah.
How much you take with the microdosing?
It's usually 0.1 to 0.3 grams. So quite a bit less. If you think of 3 grams as your kind of entry-level macro dose, it's probably, 0.3 would be 10% of that, and 0.1 grams would be 3 to 5% of the macro dose. So it is typically pretty small for a true microdose.
There is no overdose with psilocybin. Even if I used to take 5, if I take 10, it doesn't matter, or it is.
Well, it depends on what your definition of overdose is. So if you look up in the dictionary, an overdose is literally any time you get an effect that's stronger than what you intended to. So from that perspective, absolutely you can overdose on psilocybin. But usually when people, in the public think of overdose, they think of, I was at real risk, I had to go to the hospital, I almost died, right? From that perspective, no, I don't think anyone's ever truly overdosed on magic mushrooms or psilocybin. So you can definitely bite off more than you could chew from this kind of psychological perspective, but again, physically, very, very safe. Increased blood pressure and heart rate, and interestingly, if you look at clinical studies, psilocybin actually increases your blood pressure and heart rate to a similar amount of MDMA, but for some reason, if you look at recreational literature, there's almost no reports of any type of cardiovascular event happening with psilocybin mushrooms, where there's plenty of reports of cardiovascular events happening with ecstasy. So I'm not really sure what the deal is here, but it just seems like although both of them raise blood pressure and heart rate, maybe the stimulant still has more risk to it.
People don't dance with mushrooms so much as they do with ecstasy.
Well, they don't dance as much with perhaps, and also, you know, it's hard to cut dried mushrooms with methamphetamine, whereas it's pretty easy to cut MDMA with methamphetamine and caffeine, which, you know, also would kind of increase those risks together. So again, you know, is it the drug itself, or is it this kind of illegal prohibition context that's introducing unnecessary risks for people? Overwhelming difficult emotions. Physical discomfort is really interesting, reported in clinical trials very frequently. So it's not just emotional discomfort, it's just like, I feel just icky in my body. It's just very physically uncomfortable sometimes to be on psilocybin mushrooms, or really any tryptamine type of thing. LSD can do that too.
No, I'm listening.
Okay. Post-use headache. So this is like really the only kind of day after effect that they've found. It seems like somewhere between 25 and 50% of people report that they have like kind of a mild tension type of headache. So this is not a migraine or cluster headache. It actually seems like they're being studied to treat those. But people just get kind of your normal run-of-the-mill vanilla type of headache the day afterwards. And you know, usually ibuprofen, acetaminophen, or paracetamol would probably take care of the headache. If they wanted to treat it, you could just ride it out because it's typically not very severe. And for the benefit that is being delivered in clinical studies, this post-use headache is a very small price to pay overall.
Ben?
Yeah.
I've been told by a neurologist that psilocybin is used in lab experiments to induce seizures in rats. So it's no. So because you told me that there's a risk of seizures with psilocybin that is used there.
Seizures and tryptamines is kind of an interesting thing, in that there's really not very many reports of it at all. They still have epilepsy or seizures as contraindications in the clinical trials, but I think the phenethylamines, like your MDMA, is much higher risk for a seizure than a tryptamine like psilocybin or LSD.
People that are with cancer and they do all processes of I don't know.
Anxiety?
לא, כל מיני חומרים של הקרנות והחומרים של כל הטיפולים. Yeah, so I've been told that of all of them, it's easier with mushrooms. Is it possible to add it to, you know...
To add it to like a cancer regimen?
Something to release, anxiety.
Yeah, so I mean this is exactly how it's been studied, is for end-of-life anxiety associated with life-threatening illness. Most of the people in those trials have cancer.
They have chemistry, other chemistry that enter into the body, and how does it work with it?
Yeah, so that's like a good question that I don't necessarily think that we have the answers to. In the psilocybin studies where people did have cancer, they were allowed to continue their chemotherapy, their radiation therapy, or their like biologicals. They usually spaced it so that you would take your dose of psilocybin maybe 2 or 3 days before your next round of chemo. That way you've given the person time to kind of recover from the nausea and vomiting and all sorts of other icky side effects that come along with things like chemotherapy. They also permitted them in the cancer trials to be on long-acting pain medications like opiates. So if you're on an opiate every 12 hours, they would allow you to continue doing that. You just had to take the psilocybin 6 hours after the opiate. So I think that, yeah, is that ideal to be taking chemotherapy and opiates along with psilocybin? Probably not, but the results that they're getting are very, very positive And it kind of seems like, again, you've got to meet people where they're at. It's like you can't really expect them to stop taking their opiate pain medication that they're physically dependent on when they have a progressive cancer and stop their chemotherapy to do a psilocybin experience. They would probably never sign off on a trial like that because it seems like it would just be putting somebody basically at risk of premature death from their kind of cancer.
So up to 3 days before?
Yeah, so chemotherapy is variable, but it's usually done every 2 weeks as cycles. So, you know, you probably want to do it 10 days, 11 days after their last treatment, or 2 or 3 days before the next one. Ayahuasca. This one is actually 2 different drugs, or 2 different sets of drugs. You've got dimethyltryptamine as well as your harmala alkaloids. So the ayahuasca vine is Banisteriopsis caapi, and it has what they call harmala alkaloids. Sometimes in the literature you'll hear these referred to as beta-carbolines. And you have your DMT-containing plant, which is typically Psychotria viridis. This is chacruna, but sometimes they use Diploteris cabrina. This is chaliponga. Is typically consumed ritually as a beverage. Not always, like people do solo ayahuasca things, but definitely in a traditional setting it would be consumed as a kind of ritual ceremony. So again, like what's in it, so you've got your psychedelic DMT. It doesn't have serotonin, this is just there for reference, but this is DMT, looks very similar to serotonin. Then you've got your monoamine oxidase inhibitors, which actually are indole alkylamines. You see that ring there, but again, it's kind of rigidified and leads to inhibition of monoamine oxidase, or the enzyme that breaks down serotonin. So ayahuasca essentially limits the metabolism of DMT, because DMT, like serotonin, is degraded by monoamine oxidase. And then, I mean, in ayahuasca circles or ayahuasca traditions, you know, ayahuasca is the healing part. It's not necessarily the DMT according to kind of traditional cultures. Do I think DMT is therapeutic? Yeah, I do. But according to kind of traditional cultures, you know, the healing is the vine, which is the ayahuasca plant. Okay, so there's really kind of a couple different types of drug interactions that you can get, or drug and diet interactions, I guess I should say, due to the monoamine oxidase inhibition. And that's really the key to the drug interactions with ayahuasca, is thinking about what drugs interact with monoamine oxidase inhibitors, or what foods do. So you get with diet, and particularly diet that has an amino acid named tyramine in it, which is found in all sorts of fermented foods. You can get what they call a hypertensive crisis, or very, very high blood pressures that lead to things like a bleeding stroke in your brain, or a hemorrhagic stroke. With drugs, it's mostly about serotonin-based drugs, and kind of the big 2 classes are drugs that release neurotransmitters. So MDMA releases serotonin, amphetamine releases dopamine, norepinephrine, and drugs that block serotonin reuptake. So these are things like your SSRI antidepressants, tricyclic antidepressants. There's also some other drugs, things like methadone actually inhibits serotonin reuptake. Tramadol does as well. So there's a few that aren't necessarily antidepressants that also have that kind of property to them. And so, I mean, monoamine oxidase inhibitors were the first antidepressants, so we've known about these interactions for a very long time. They're very, very well documented, but it's a little bit different in that the pharmaceutical antidepressants bind monoamine oxidase in a way that it just completely knocks out the function of that enzyme, and the body has to build more of it, and that takes about 2 weeks. So the recommendations you'll see for pharmaceutical monoamine oxidase inhibitors is to basically, you cannot take a serotonin drug 2 weeks after using a monoamine oxidase inhibitor, and then before the monoamine oxidase inhibitor, you have to discontinue whatever other interacting drug with an adequate time frame for that drug to be eliminated, which for most antidepressants is still about 2 weeks. For some, like Prozac or fluoxetine, it's much longer. It could be 5, 6, or maybe 7 weeks. So this reversibility of monoamine oxidase inhibition with ayahuasca kind of sets it apart. in that beforehand, yeah, it's still about the drug that you're concerned about. So you still need to avoid the Prozac for 5 or 6 weeks before ayahuasca. After ayahuasca, though, your body gets your monoamine oxidase function back pretty quickly, probably in 48 to 72 hours. Why you would want to start Prozac again 72 hours after your ayahuasca experience, I'm not quite sure. But, maybe there's some other serotonin drug that you're interested in, or, goodness knows what's going on. You're at the, there was just, ayahuasca I think just got banned in the Netherlands because there was some retreat that was called, I think like the Heroic Retreat or something, that was kind of like, we're going to do ayahuasca and ibogaine and 5-MeO DMT all in the same weekend. And it was just kind of like, this is just crazy unsafe, and just can't believe that there are people that would do that to other human beings out there. So these are some foods and drinks that have tyramine in it. These are kind of fermented things. With the monoamine oxidase inhibitors, the pharmaceutical ones, I do think the risks are higher compared to with ayahuasca. And tyramine as an amino acid is actually metabolized and eliminated from the body very, very quickly. So you'll meet some people that are kind of like, you cannot have sauerkraut within a week of drinking ayahuasca. And actually, the half-life of tyramine is about 30 minutes, so it's completely eliminated from the body in 2 or 3 hours. So you could have sauerkraut for lunch and drink ayahuasca later that evening, and you would not be at risk of a hypertensive crisis. So really with the food, it's about avoiding it during your ayahuasca experience. Please don't have, a bunch of blue cheese, aged soy sauce and stuff in the middle of your ayahuasca experience. And to people that know ayahuasca, this just kind of sounds hilarious, right? Because it's a very physically purgative medicine. You're usually vomiting, and the idea of like having blue cheese is just kind of like, no way, Jose. But people are experimental, and someone will try it sooner or later if you don't put the information out there. As far as drug contraindications with ayahuasca, this is not an all-inclusive list, but it's a pretty good list. And again, really what you see is serotonin-based antidepressants. Lithium, a mood stabilizer for bipolar disorder, so probably not a good candidate for ayahuasca already if you're taking lithium, because you probably have bipolar disorder, but also interacts with monoamine oxidase inhibitors. Antipsychotics, any of them would not be a good idea really to combine with ayahuasca, because probably the risk would be that ayahuasca just doesn't work. But one, particularly ziprasidone, the brand name in the US is Geodon, also inhibits serotonin reuptake, so there's that same, it blocks serotonin reuptake pump, there's a risk there. Drugs, stimulants that release neurotransmitters. Herbs, so sometimes people are kind of like, I don't like pharmaceutical antidepressants, so I just take St. John's wort, so that must be completely safe, right? It's kind of like, not really, it's serotonergic as well. Kratom, I have a question mark here because there are some people that have reported some kind of nasty types of things with kratom and ayahuasca. Your cough and cold section, so things like Robitussin or dextromethorphan also inhibits serotonin reuptake. Your Sudafed is basically a stimulant amphetamine that's used for cough and colds. Chlorpheniramine is an antihistamine drug, but it should be a tricyclic antidepressant because that's literally the structure, and it's kind of weird that they market it as an antihistamine, really. Weight loss drugs, anytime anyone's claiming it's a miracle cure for weight loss, it's almost surely a stimulant that's in there. And kind of along with that, like if you go to a supplement store and it says this is all natural, and it doesn't say weight loss, but it says increases metabolism, fat burning, like these are the kind of key words that you should kind of hone in on as far as like this probably has a stimulant in it, and it's probably not a good idea to try to combine with ayahuasca. Not all pain medications, but certainly some of them, like your methadol, tramadol, tapentadol, meperidine, they all inhibit serotonin reuptake. So again, like this list seems extremely diverse and weird and all over the place, but it can usually be traced back to one of two things: releases neurotransmitters like serotonin, norepinephrine, or dopamine, or blocks the serotonin reuptake pump, or kind of the two tried and true ways to get yourself in real hot water, or serotonin syndrome. Then you have your kind of ceremony or recreational things, so all these different phenethylamine compounds, the Shulgin compounds. This is the anomaly. the tryptamine 5-MeO-DMT, and nobody quite knows why there seems to be this risk of serotonin syndrome with 5-MeO-DMT, but not necessarily psilocybin or LSD. And I have found some data in rodents that demonstrates that it does block the serotonin reuptake pump 5-MeO-DMT. So I don't think that it's because it's a tryptamine it has this risk. I just think that 5-MeO-DMT has some other pharmacology to it, like blocking serotonin reuptake pump, that would make it like, well, yeah, that's what they all do.
Is that again during the ayahuasca trip?
So
Or
all of
before?
these depend on, well, definitely
The
during,
5-MeO.
but it also depends on beforehand, right? So we have this
Specifically the
concept
5-MeO.
called half-life, which is basically the time it takes for 50% of a drug to be eliminated from the body. And they think that, do I have it here? Oh yeah, here. So you're planning your weekend ayahuasca ceremony. You want to stop the drug in question, the interacting drug. So any of these on these lists, 5 half-lives at least before the ceremony begins. And you can just take whatever drug it is and just Google half-life of sertraline, half-life of
What is
fluoxetine.
half-life?
Half-life is the time it takes your body to eliminate 50% of the drug. So let's just say a drug has a half-life of 1 day. I stop taking it, 1 day later, there's still 50% of the drug left in my system. 2 days later, there's half of a half, or 25% of the drug left in my system. 3 days later, 12.5%. So after 5 half-lives, there's about 3.5% of that drug left in your system, and that's when we as pharmacologists kind of draw the line and say, for all intensive purposes of worrying about drug interactions, that should be long enough. 5 half-lives.
The word coffee wasn't written all over it.
It was.
Coffee.
Coffee?
Yeah.
So with
as food and also as caffeine and the stimulant.
probably in moderation, it's okay, but it is a stimulant. It doesn't release dopamine, norepinephrine, so from that perspective, it might be okay. But with the pharmaceutical monoamine oxidase inhibitors, there were people that were just very sensitive to caffeine and did get kind of very high blood pressures. So.
What about combo? It says combo.
Yeah, so combo. So that's one I didn't really mention. Is the purgatory. Okay, sweetheart, but these are really important questions. Like they're very important questions. These are like life or death questions here. They're not just kind of right. So the purgative sacraments. There's just been a few times where people go to these retreats again, and it's kind of like, we're going to drink ayahuasca 4 nights in a row, and then during the daytime I'm going to give you combo, and then the next day I'm going to give you a tobacco enema, and it's basically like there's only so much purging that you can do before your body just runs out of electrolytes and you're at risk for seizures or arrhythmias. So that's kind of why I say combo, and I don't mean that like, okay, you do ayahuasca, it's 3 or 4 days later, you've had a few good meals, you got some salt back in your body, can you do combo? Yeah. I'm just talking about you probably shouldn't do ayahuasca, then combo, and then some tobacco cleanse, and then ayahuasca again, and expect to be able to do that for a week and have it be completely
I've
safe.
done it for a week. I was fine. Like 3
Yeah,
ceremonies,
Still with
3
Yeah,
conversations.
so with these drug interactions, the laws of statistics are operating, right? So if you think about this, let me put it this way. Maybe there's a risk of something severe happening mixing combo and ayahuasca, and the risk is low, 0.2%, 1 in 500. So 499 people are going to do fine, but one of those people is going to have a really severe and bad outcome. If you're a facilitator that's pouring ayahuasca and you got 20 people in each ceremony and you're doing that every other weekend, you're going to be serving thousands of people in your life. So a 1 in 500 chance is just too high to take. So if you're an individual, you want to assess yourself what the risk is, you feel okay with that, that's your choice, right? But I kind of feel like if you're the person that's facilitating, pouring for others, then you need to think about like, okay, the risk is very low, but the outcome is very, very severe. So I don't want to play with that kind of hot water, right?
Ben, one small question about the, like 6 weeks of all of these medications should be fine before an ayahuasca ceremony? 6 weeks is like a And as an estimate.
6 weeks will cover just about anything.
Okay, cool.
Yeah.
Perfect. Thank you. Thank
The
you.
like even methadone or Prozac, you would be covered in 6 weeks.
Thank you.
Yeah.
Thank you.
All right. So you're going to stop your neuroactive drug 5 half-lives ahead of time. You're not going to. I have a 24 hours of here, but again, you know, you're not going to have soy sauce or sauerkraut or something during your ayahuasca experience. You know, if you're doing a Friday, Saturday experience, this is probably when your risk is highest. And then post-ceremony days, day 1, your risk is already much lower, but probably by 3 days afterwards, 72 hours, you're back, your monoamine oxidase is functional again, and you could resume any type of drug, supplement, or food that you wanted to. I've covered a lot of this. I think the only one that I haven't really covered here, well, maybe the vomiting, but really like low blood pressure. So monoamine oxidase inhibitors actually drop your blood pressure, and when you go from sitting to standing, you can get very, very dizzy. And so kind of the caution here is that if you're in an ayahuasca ceremony, stand up slowly. You know, if you need something to kind of get your balance, if you start going into the light, sit down immediately because you're probably about to pass out and you could fall and hit your head. Aspiration, so again, like, okay, purgative, the nausea can come on very quickly. So it's like maybe for the peak of the experience, you really should be sitting up, or if you absolutely have to lay down, be laying on your side. Because that way, if you're vomiting, you're not going to choke on your vomit and get it into your lungs and end up with some type of aspiration pneumonia. Ooh, yeah.
About fainting on the ayahuasca, at least I asked because it happened to me a few times, even when I lay down, I faint.
Yeah. Yeah, it can be pretty intense. Yeah, yeah. So I mean, laying down, it would be kind of strange to faint laying down, but yeah, probably just even laying, going to sitting, that could be enough to be like. It's transitions, right? So it's sitting, so it's laying to sitting, sitting to standing. Those are the high risk times for fainting. Yeah. Ibogaine is not a short one as far as risks go. I'm sorry.
Well, yeah, maybe
I don't know.
you guys are about an hour and a half behind schedule. It also looks like we're probably not going to be able to cover everything that we wanted. We just have this thing where we always want to over-deliver a lot of value, and then there's never enough time.
Can you just talk about candy?
That's how
זה
better.
כמה פחות פופולרי בישראל, כאילו, פחות מדובר פה.
לא, דלג זה חשוב.
Skip ibogaine.
No, ibogaine is very important.
Skip the ibogaine?
No,
We can stop the question.
questions later.
last question? כן, עושים את זה בארץ, כן. עושים את זה, זה חשוב ממש.
כן, יחד אנחנו לא עושים דברים אחרים גם.
אנחנו לא חיים רק
If
בארץ.
anyone has any specific questions about ibogaine, you have the material
Yeah.
also in your slides, and maybe you can come up later and ask.
I have an email address.
Yeah.
I'll be here at lunchtime.
Yeah, we have
We'll
to
take care of you.
you.
Okay, so boga, it's a root shrub from West Africa. It's very novel. It's very different than other types of psychedelics. It has demonstrated very, very broad anti-addictive properties in mice and rodents, not just for opiates, tobacco, amphetamine, cocaine, alcohol, you name it. It seems like ibogaine has an anti-addictive effect. But it's unique with opioids because it seems to block the withdrawal effects too. So could it treat cocaine use disorder? Sure, but does it block the withdrawal effects of cocaine? Not really. Alcohol, benzodiazepine use disorders, could it treat them? Potentially, but does it block the withdrawal effects of alcohol? No, but it does with opioids. So that's probably why ibogaine is so famous for being able to get people off of things like heroin, is because it not only tackles the kind of psychological aspects of addiction, but it also helps with the physical aspects of addiction. Cardiotoxicity is probably the big risk with ibogaine, and you know, there's been several deaths reported in the literature, sometimes even in quote-unquote clinical settings. So I think this one is kind of set apart from some of the others where like, okay, yeah, if someone died from taking ecstasy in a recreational environment, sure. Has anyone died in a clinical trial? Not even close. There's not even been a serious adverse event. Whereas it seems like ibogaine, yes, there's real medical risks even in controlled types of settings. So as far as dosing ibogaine, there's not really an optimal dose established. The papers in the literature kind of seems like 8 to 20 mg per kg of ibogaine is enough to detoxify someone from opioids. The literature does have clinics that go up to 30 mg per kg, but those are the ones that have reported a death. So it seems that over 20 mg per kg may be unnecessary and kind of increase the risk more. They did this kind of analysis of fatalities or people that died and found a very wide range of doses. So again, it's kind of like, okay, 4.5 mg per kg killed someone, but the kind of caveat here is that they all had some type of advanced cardiovascular condition or they were combining with something else. So they took their ibogaine, and maybe it was a very weak dose of ibogaine, so they didn't really get what they thought they were going to get out of it, and then 8 hours later they left and went to smoke some crack. Okay, well, yeah, you're going to be in probably really hot water if you kind of do that type of thing. So with ibogaine, they kind of do tests and boosters sometimes. So oftentimes an ibogaine clinic will give someone a small test dose ahead of time to kind of see how they respond to it, and kind of gauge their flood dose or how much more they should give them from that. And then similarly on the backside is that it does a very good job of blocking the physical withdrawal effects, but sometimes 3-4 days after your big ibogaine experience, some of that opioid withdrawal starts to creep back in, and oftentimes they'll give just another kind of booster, not trying to get them necessarily back into a full dosing space, but just enough to kind of stave off the residual effects of the withdrawal syndrome. So prior to ibogaine use, you probably should do a heart workup. You should get an EKG. You should probably get an electrolyte panel as well to make sure that some, like particularly things like potassium and magnesium are normal. You should probably also get some liver function tests because ibogaine is heavily metabolized by the liver, and if you have cirrhosis or some other advanced liver condition, then ibogaine is probably contraindicated, or at the very least you should be using a lot less than somebody else. There's actually a guideline that's out there by the Global Ibogaine Therapeutic Alliance about how to administer ibogaine safely. And they actually recommend that during your big or flood ibogaine dose experience that you have a continuous heart monitor on you that's monitoring for arrhythmias and things like that. They also recommend that you have crash carts or medications to treat arrhythmias if they would occur, and obviously personnel that understand and know how to use those medications if the event should happen. It helps to have an emergency department nearby with kind of admitting privileges and the ibogaine clinic I got some data from in Mexico had an emergency department physician that was part of their ibogaine clinic, and he also had admitting privileges at the local emergency department, which was pretty close by. So ibogaine is not notorious for being necessarily a very euphoric type of drug or euphoric type of experience, and it's also an incredibly long type of experience. You can feel dizzy, off balance. You can vomit, but it's usually only one time, and it's usually like when you kind of first stand up. It seems that ibogaine affects a part of your brain that detects like a motion and balance, like the cerebellum. It's kind of this back here, and you can feel what they call like ataxic, or to be like very like off balance with it. There are tons and tons of drugs that prolong part of your EKG called the QTC interval. So drugs that prolong QTC interval are probably contraindicated, or you really should avoid them with ibogaine. And then ibogaine, again, metabolized by the liver. There's all sorts of enzymes in your liver. There's one specifically called CYP2D6, and many drugs inhibit this thing, which tends to boost the concentrations of ibogaine. So they've done one study that used an SSRI called paroxetine. The brand name is Paxil. It's a very strong CYP2D6 inhibitor, and they found that this literally doubled your blood concentrations of ibogaine. So if you're kind of thinking about a drug where it's kind of like, okay, 20 mg per kg is therapeutic for heroin, 30 mg per kg might kill you, and then you have a drug that's boosting it twice as much, well, that 20 mg per kg just became 40 mg per kg, and that sounds really dangerous. Ketamine, dissociative anesthetic, analgesic, antidepressant, and psychedelic. Goodness knows what it is, all the above. Seems that it works by changing the function of glutamate. It blocks a glutamate receptor called the NMDA receptor, and possibly opioid neurocircuits as well. There's been some data recently showing that if you give someone an opioid blocker like naltrexone, the ketamine tends to not work as well. You don't get as much of a dissociative effect, and the kind of effects on mood are also kind of reduced. So it seems that at this point we think that ketamine works for glutamate and opioids. It has been approved in the US for the treatment of depression. I think the kind of cool part, and maybe the big take-home here for different types of psychedelics, is that ketamine works for bipolar depression. It's not contraindicated in bipolar depression, so all the other ones really are sort of contraindicated in bipolar disorders, where you get someone with bipolar disorder, they're like, hey, can I try MDMA? Probably not, but like if you really want to get into this type of work and do a guided assisted psychotherapy session with a mind-altering drug, why not ketamine? Let's start there and see how you do. As far as dosing ketamine, it's very, very different depending on what you're trying to do with it and the route of administration that you're using. So for your kind of mood or antidepressant effects, the most common dose they use is 0.5 milligrams per kilogram. So that would be 35 milligrams in a normal weight, like a 70 kilogram type of adult. But they're doing those through intravenous infusions, right? So if you're doing something like an intranasal, which is typically how ketamine is administered in a recreational setting, it's usually snorted, then you may actually need kind of more like 2 to 4 times that kind of amount to get a similar effect. So probably 30-35 milligrams intravenous is going to be similar to 100 milligrams of snorted ketamine. Ketamine as an anesthetic is much, much higher. This 2 is probably more like sedative doses, whereas you see anesthesia really starts more like 6 mg per kg, so way higher than the types of doses that they use for mood disorders. So ketamine, because it is an anesthetic, it puts people to sleep in large doses. You have to kind of be careful when you start combining it with other drugs that make you drowsy or have sedative types of effects. Things like alcohol, GHB or gamma hydroxybutyrate, benzodiazepines.
That's like some honesty.
Pardon?
GHB, they call it the some honesty.
Use it for rape, like
Yeah, so all of these drugs, well, not opioids necessarily, but benzos like roofies is flunitrazepam, so that's a benzodiazepine. GHB, yep, and obviously we know you drink enough alcohol, you black out. So the kind of thing that these drugs all have in common is they tend to cause amnesia in large doses or when you mix them together, and they also tend to, especially when you mix them together, put you at risk for stopping breathing or having very low types of respiratory rates. Ketamine is also associated with lower urinary tract symptoms, the worst of which would be hemorrhagic cystitis, or basically a bleeding bladder. Painful, horrible, blood in the urine. This is mostly associated with frequent and heavy ketamine use, but the way they are using ketamine in clinical trials and the way that that's actually been practiced, at least in initial round, is usually to get 2 or 3 treatments a week for 2 or 3 weeks in a row. So it kind of seems like, okay, depending on, now that it is approved, you have doctors that are probably going to want to start pushing the envelope. So I kind of wonder about, will we start seeing lower urinary tract symptoms show up in clinical environments because of this kind of repeat dosing type of practice that they have going on. Ketamine does increase your blood pressure and heart rate transiently as well. It is associated with nausea and vomiting, and it can be very synergistic with other types of psychedelics, which can just put you at risk for a massively overwhelming type of psychological experience. Especially, ketamine is very popular in club type settings, so you're dancing, you're having a great time with MDMA, and your buddy's like, hey, you want to snort some ketamine, and that sounds like a great idea, because everything sounds like a great idea on MDMA. And then all of a sudden, you're kind of like in way too deep and in this very public and crowded type of environment.
How long is the journey with ketamine?
Ketamine's pretty short. Probably, it again depends on the route of administration, but probably you're gonna, have a peak within 10 or 20 minutes, and the whole thing's gonna be kind of 30 or 40 minutes. If they give you an intravenous infusion, they usually give the infusion over 40 minutes, so that's probably going to take an hour, because the infusion goes for 40 minutes, and then there's going to be kind of 20 minutes where you kind of come back to baseline. Yeah. Okay.
Can I ask about
Yeah.
in Israel, we have a nice guy problem.
Nice guy problem?
Yeah.
Synthetic cannabinoids.
Yeah, and just a lot of addiction, especially the homeless and people with not, enough financial, like people that live on the streets, like that.
But it
Very
doesn't have
popular.
to do so much with healing.
No, it's not, doesn't have to do. I just want to know what they call it if they have in the States.
Well, skills
They usually call it like K2 or spice, synthetic cannabinoids though.
Okay.
They're marketed as all sorts of different names, but yeah. The thing about those is, I don't know, I think we need to go to lunch. I can talk more about the synthetic cannabinoids we do at lunch if you want, but yeah. They have much higher risk than tetrahydrocannabinol or regular THC. They have different pharmacology to them. THC only causes partial stimulation of cannabinoid receptors. A lot of these synthetics cause full stimulation that does have additional risks associated with it. Yeah. All right. We went through the risks of each of the substances. Now we're going to kind of integrate the risk of those substances with traditional psychotropic or drugs that treat mental health conditions. So psychedelics and most psychotropics, and in this presentation when I say psychotropic, I just mean a pharmaceutical that is meant to treat some type of mental health condition. That's what it means. So it seems like they have these kind of almost divergent mechanisms of actions where psychedelics have this snow globe effect or kind of agitating the mind and bringing up repressed things. It seems like psychotropics are about tolerating a difficult situation, kind of numbing your emotions out potentially, and you can understand that, okay, like it seems sort of counterproductive in some ways to, on the one hand have a group of drugs that is helping you tolerate difficult emotions, and then have another set of drugs that are trying to bring up difficult or repressed emotions. So it seems sort of a little bit counterintuitive from a logical perspective to want to combine psychotropics and psychedelics. However, there's so many unanswered questions here, I'm a little hesitant just to blanket say that it's a horrible idea for everyone. So I really think that this kind of potential needs to be sort of weighed against the risks of tapering and discontinuing the psychotropic medication that the person's taking. And it should be aligned with the goals and interests of the user themselves. I mean, some people may absolutely want to try to taper off their psychotropics and kind of heal themselves with psychedelics and go a different path. Some people may not be so sure, convicted in that, and want to kind of see, like, well, can I use a psychedelic with my psychotropic and get a little bit better, and then maybe I'll just be in a better mental space to want to taper off of my medication. So a lot of psychotropics actually diminish effects of psychedelics, and this type of interaction, I think, kind of depends on how much does it diminish effect, and what is the person trying to get out of it? Because okay, say it takes the edge off your psychedelic experience by 20%. Man, well, 80% of the healing a psychedelic delivers still sounds pretty good to me. Whereas if it's diminishing the effect by 80%, then it kind of seems like, gosh, that might not be worth it to really try to combine your psychotropic with this psychedelic. The kind of flip side of that is things that are potentially dangerous with psychedelics. And in this case, obviously there's physical danger involved. You are going to want to either avoid the psychedelic or taper and discontinue the psychotropic before you engage with the psychedelic. So this is kind of my spiel here as a pharmacist, is that I meet many people, consult with people that are interested in doing psychedelic sessions or going to psychedelic retreat centers, and the moment they tell someone I'm taking a psychotropic medication, they say, well, we can't do that here, so you need to call me when you're off that. But they don't give them any type of information about how to get off of it or how to get off of it safely. And I've had certain people come up to me and just kind of be like, well, what should I do? Should I just lie about it and continue taking the psychotropic, or should I just stop taking all my mental health meds all at once? And neither of those options are really very safe for the person. Lying to your facilitator could put you at risk of some type of physical danger, but now you're introducing intentional distrust into that kind of therapeutic container relationship. And then the other way is just abruptly stopping your your mental health medications, you're really putting yourself at risk for going through a horrible withdrawal syndrome. And oftentimes, the worst of it is, stopping antidepressants all at once can make people feel suicidal. And, God, talk about set and setting. That sounds like a kind of a bad place to be.
Psychotropic, you mean all psychiatric
Yeah,
medications?
yeah. That's the word psychotropic. It means to all of them. I am generalizing a little bit here as far as I think that most of the psychotropics do work to diminish or kind of repress emotion or help people tolerate difficult emotion, but that may not necessarily be a blanket rule. So kind of my thing here is how will the intended psychedelic user be supported in this process? And Cherie's going to continue talking about preparation. And I would urge anyone that's interested in facilitating just to start thinking about this as kind of okay, what if I do run into a really good client except for they're taking some type of psychotropic and they need to taper off? Is it really the responsible thing to do to just tell them come back to me when you're off of it? Or should I start providing my emotional support services right now and treat this tapering off and discontinuation as a great tool to prepare the person for maybe difficult things that come up, how to cope with difficult emotions, and kind of building that trust and rapport before you even enter that psychedelic space with the person. So what should you do to taper or not to taper? These are some of the key questions I ask people in consulting types of interviews that I do with them. First of all, I want to know, what are you getting out of this drug? Is it helping you in any way? What does it help you with? And then the flip side of that is, what are you not getting out of this drug? Where is it lacking, or what types of side effects are you kind of currently experiencing? What is your goal regarding these medications? Sometimes I get people and they're kind of well, I take 2 antidepressants and a benzodiazepine and I just want to get off of them. It's kind of okay, well, not that goal is completely inappropriate, but it's probably inappropriate to try to stop all 3 of them at the same time. This is going to be a long-term thing where we sequentially get rid of one. Maybe you can do some work with a psychedelic off of one or not, depending on the substance you want to use, and then we're going to kind of continue with the process and peel these things off gradually. We're not going to tell you that it's realistic to think that you can just stop these 3 drugs that you've been taking for the last 5 years and expect that nothing is going to happen and that you're going to feel great and just kind of stable in that type of environment. So what's the compatibility between their current meds and the psychedelic substance of interest? I have a feeling that this is probably the big question for the audience here, and I have a nice chart that I will go through with you in a slide or two. What are the balance and risks of stopping or continuing the medication? And I kind of spelled it out here that the risks of stopping the medication is probably going to be a withdrawal syndrome or their illness coming back, the symptoms coming back. What are the benefits? Well, if it potentially diminishes or kills a psychedelic experience, you're going to get the psychedelic effect back, which could, mediate a deeper healing type of experience. And, not that you can't taper meds off by yourself, but I always feel like you should just tell your doctor at least that you're trying to get off of them and list them for help, because, maybe you can talk to your doctor about your tapering off to use a psychedelic. Maybe you can't. That really depends on the relationship you have with your doctor and the level of friendliness or knowledge they have around psychedelics. But they should be listening to you as a patient or client, and they should be hearing you when you say hey, I want to try something else. This isn't really working for me. Will you help me taper off the medication? They may try to convince you, I think you need to stay on to this and that. But I think if you're strong-willed enough and say hey, I'm going to stop this. Will you help me or will you not help me? If you kind of put them in that situation, then I think most of the time they're going to be well, of course I'll help you, right? And they can be helpful in prescribing step-down doses. Oftentimes you're going to need to kind of taper off gradually. They'll be able to advise you on the rate of taper. So oftentimes I meet people and they're I tried to taper off and I just couldn't do it. I'm kind of well, what'd you do? And it's well, the first thing I do was cut the dose in half by 50%. It's oh, well, that was just way too much right off the bat. You probably should have started with 10 or 20% and kind of see what happened and continue from there. And typically when you're tapering medications, the closer you get to the finish line, the harder it is. Usually the first couple steps down, the person can do relatively easy, and the hardest step of all is just completely stopping the medication. That one seems to be the one that is the most difficult for people. So do you have to taper off every medication? Well, maybe it really depends on, again, their intentions, what they're trying to get out of it, how bad the interaction is. So you may just be able to hold a medication temporarily. Oftentimes, the withdrawal syndrome for medication doesn't kick in until 3 to 5 days after you've stopped taking it. Yet most of the drug is eliminated after 1 or 2 days. So it kind of seems that, well, gosh, you could just take a 1 or 2 day break before your psychedelic experience. Maybe that would intensify the subjective effect, give you a pretty good healing effect, but you wouldn't necessarily have to run into that withdrawal syndrome. And I think some of the benzodiazepines are probably like the types of drugs that I kind of think about as far as like, especially on a longer acting one like Valium or something like that, okay, or diazepam I should say, taking 24, 48 hours off might give you a little bit more of an intense psychedelic effect, but it's probably not going to put you at risk for a really bad withdrawal syndrome because you'll be able to resume that medication very shortly after your experience before it really kicks in or gets severe. So this kind of came up in the previous presentation with ayahuasca is the half-life or the time it takes the body to metabolize 50% of a drug. And again, the example here is this time I have an example of 2 hours. So if it has a half-life of 2 hours, after 2 hours, 50% less. After 4 hours, 25% left. After 6 hours, 12.5% left. And for all intensive purposes, a drug is usually considered to be eliminated from the system after 5 half-lives. Some caveats or exceptions to this rule are drugs that have active metabolites. So sometimes it's not just the drug. So Prozac or fluoxetine is like that, in that fluoxetine has a fairly long half-life, kind of like a 2 to 3 day type of half-life, but it has a metabolite that is active called norfluoxetine that has a half-life of about a week. So that's why that one really needs to be stopped kind of 6 weeks ahead of time, is because it has active metabolites that just hang out in the body for a very long time. I think the other thing to keep in mind here is that when you look up a half-life on the internet, it's a population estimate, so it may not be specific to an individual. So if you're kind of thinking that, well, hey, this is a population estimate, well, it's probably in healthy adults or adults that are taking the medication. And if you're dealing with someone that's elderly or someone that knows they don't have the best kidney function or something like that, then maybe you want to add a little bit of a buffer space on that 5 half-lives because you sort of suspect that they metabolize a bit slower. So there's many different types of psychotropic drugs. The antidepressants are probably the ones that are the biggest and the most frequent ones that people have questions about, because at least according to the American Psychiatric Association, and I assume it's fairly similar in Israel, if you got depression, antidepressants. You got anxiety, antidepressants. You got obsessive compulsive disorder, antidepressants. You got PTSD, antidepressants, right? So all of the types of illnesses, or the vast majority that psychedelics are being studied for, the kind of first line or typical recommendation is going to be an antidepressant. So as this kind of psychedelic healing paradigm comes into focus, you're going to meet a lot of people that are on antidepressants that want to try psychedelics. Probably benzodiazepines are number 2 because these are really commonly used for anxiety disorders. Stimulants, also pretty common, both for ADHD, and oftentimes they're used for, increasing energy or decreasing fatigue associated with depression or, chronic fatigue syndromes, things like that. Analgesics are painkillers, so it's oftentimes, it's very hard to feel extremely well mentally when you're in chronic pain. Typically, there could be there just could be all sorts of things going on there. Sometimes chronic pain is kind of insidious and involved with a disease. Sometimes it happens overnight, is that you're a healthy individual and then you have some type of car accident and now you've got a bad back and you can't play basketball and all your friends don't hang out with you anymore because they play basketball, and you're left with this kind of traumatic car accident chronic pain, and really having to kind of completely change your life. So, this is the type of thing that the transformation that psychedelics could probably be pretty helpful for, but, there's, painkillers involved. Antipsychotics and mood stabilizers, I'm going to talk about a whole lot less, mostly because these drugs are kind of the first-line medications to treat psychosis or schizophrenia, as well as bipolar disorders, which are typically contraindicated with psychedelics. Again, you can use ketamine for bipolar depression. However, you will meet people that, in this day and age, the antipsychotics have kind of left psychosis and bipolar disorder, and some people are taking low doses for sleep, they're taking low doses for anxiety, things like that. And, typically, how do you tell? Well, you interview the person, well, what have you been diagnosed with? But then, I personally, as a pharmacist, also just kind of look at doses. So it's kind of like, okay, you're taking a large dose of an antidepressant and then a tiny dose of an antipsychotic at bedtime. Well, I'm probably not thinking that your psychiatrist thinks that you have schizophrenia, right? Versus you're taking a very large dose of an antipsychotic and nothing else. Yeah, I'm probably thinking that your doctor thinks you do have bipolar disorder or schizophrenia, even if the person themselves in the interview says that they don't. It's still like a major red flag to me when I see large doses of those medications. Oh, so I put some lovely boxes on here that just explain everything that I just said, more or less. But I forget I had these animations, kind of like to keep me on track, but I guess I don't need it. So I think that this is really the kind of the meat and potatoes of this section as far as like what people are interested in knowing. And let's just kind of like walk through the chart a few different ways here. So first of all, you see a lot of question marks with the mood stabilizers and a lot of red. Well, maybe we should go through the legend. So red I have as contraindicated, like you should not combine them because there are severe risks possible, and I usually mean severe physical risks. Orange is probably okay at normal therapeutic doses, but you should approach it with caution. However, things like, stimulants with ketamine, that's a yellow one. All right, well, if you're taking a low dose of amphetamine by mouth for ADHD, that's still probably acceptable, but if you're addicted to crystal methamphetamine and you're actively using that, then yeah, I probably don't think that ketamine therapy is the way to go, at least while you're kind of using large amounts of amphetamine. Where green is kind of, there's minimal risks in combination. So the red, orange, green, your kind of stoplight is more about physical risks. The arrows and other things that you see in the boxes are mostly about psychological risks or the subjective psychedelic, am I blocking you? Are you okay? Can you see? Are more about psychological risks. So I have question marks when the class is sort of diverse. So there's all sorts of different types of mood stabilizers, which I haven't read because, well, they probably have bipolar disorder for one, and number two, because they're so diverse, I'm not really sure what's going on with, well, if you tell me which one specifically, I could probably tell you what's going on, but as a class, it's very difficult to make a generalization. Arrows up mean that you're probably going to run into an intensified or synergistic type of experience. Arrow down means a diminished type of experience. And I didn't put it on here, but 2 arrows down probably means it completely kills the experience and it's really not worth your time at all. Plus or minus is sort of, some people report slightly intensified or diminished effects, but sort of we're not exactly sure what the overall effect is in the average person on their experience. And then 2 dashes here is no impact, or it's very unclear. But if it's really unclear, I put a question mark. Dashes usually mean like I don't think that there's really much of an impact. Okay, so we've gone through the legend. Let's kind of go through by drug now. So MDMA, actually with most of the psychotropics, doesn't look like it's so much of a risk. It seems like the risk really is diminished experiences. The SSRIs or SNRIs, the standard antidepressants, really kill MDMA experiences to the point where I don't think it's really worth it. And some people are kind of like, well, can I just take way more MDMA to kind of overcome that? I'm not sure, but if you did overcome it, you might be at risk of some type of physical toxicity from overdosing on MDMA. So again, I don't think it's really a great strategy to try to get around this. So that's kind of the deal with that one. And again, kind of down the line, MDMA doesn't look like it's necessarily super dangerous with a lot of the psychotropics, but the biggest kind of overall risk is that it won't work. I think the exception here is stimulants, because MDMA is a stimulant itself. Of course, if you start stacking Adderall or amphetamine or Ritalin or methylphenidate with other stimulants, then yeah, you're getting additive type of stimulant effects. You're probably taxing the cardiovascular system more. Psilocybin, LSD, or DMT, these are your kind of classic tryptamine psychedelics, and they look fairly similar overall to MDMA, except I think that the kind of big distinction with MDMA versus something like psilocybin is that many people report that they still get pretty good healing effects on their antidepressants using psilocybin. And oftentimes I run into people that think that there's a risk of serotonin syndrome here. There is not a risk of serotonin syndrome. So sometimes people are kind of like, educate them, warn them, like, hey, it may not work. You may not get a diminished experience. You may not meet God, have your mind blown open, and exist in this place of oceanic boundlessness. But you might get a good hour of crying in there, and you might really feel better the next day. And if you're willing to kind of accept that, you're maybe not going to have the most mystical experience, but could get a healing effect, then okay, that could be worth trying for you. Ayahuasca now, this is where you kind of see that, wow, a lot of the psychotropics could be potentially problematic. And the SSRIs, SNRIs are just blanket out. Stimulants also just blanket out. Opioids depends on the opioid. So things like the methadone that block the serotonin reuptake pump, yeah, that one probably is going to be out. But something like your like hydrocodone or morphine probably isn't contraindicated. Whether it's really a fantastic idea or not, I leave that up to the person and what their intentions are and things like that. But from a perspective of severe physical risks, most opioids with monoamine oxidase inhibitors are probably okay. Antipsychotics probably just kill psychedelic experiences in general, but I have a question mark here because there is that one, ziprasidone or geodon, that could really have a risk of serotonin syndrome with ayahuasca. Ketamine looks pretty good down the line. There's some yellow here, mostly because ketamine is that sedative type of medication. Okay, other downers like benzodiazepines, okay, there could be some increased risk of sedation. I think that most of this risk is documented in like intensive care unit settings where they're giving people infusions of benzodiazepines and trying to give them ketamine and have some opiates on board. That's when you kind of really run into woof. But certainly in a recreational setting, you're using high doses of things, that could be a problem. But down the line, you're just using standard therapeutic amounts of these psychotropics, and you're approaching the ketamine for a healing experience. You're using the ketamine at a dose that has been kind of studied in clinical trials, then you're probably not really at that high of a risk. And again, ketamine can be used for bipolar depression.